Well, hello everybody. This is Greg Stone, and I'm here at TCT Asia Pacific 2016, and we're going to discuss some of the hottest topics in interventional cardiology right now, specifically regarding the intersection of dual antiplatelet therapy in patients with acute coronary syndromes undergoing DES treatment, and also the appropriate way to treat patients with multivessel disease with STEMI. And I'm joined here by my friends and colleagues, David Cohen, Roxana Mehran, and Freek Verheugt, and so we're going to have a great discussion here. So let's start first with the difficult issue of what to do in patients who are undergoing primary PCI for STEMI who have multivessel disease. And so first we'll go over what some of the guidelines are and then look at some of the studies. So currently the 2015 ACC, AHA, and SCI guidelines recommend, with a Class 2B level of evidence B recommendation, that in patients with multivessel disease, PCI of a non-infarct artery may be considered either at the time of primary PCI or as a staged procedure. So they don't recommend it as a routine procedure, but it's something that you might think about in certain circumstances, and it may be reasonable. That's the Class 2B indication. But the level of evidence is B, so it's not great evidence. And similarly, the 2014 ESC and EACTS guidelines give a Class 2B level of evidence for PCI of non-culprit lesions in the same procedure as the index PCI and the STEMI, but with a 2A level of evidence, say staged PCI of significant non-culprit lesions may be considered. But again, it doesn't even really give you guidance as to what are the significant lesions. Should you be using non-invasive testing? Should you be using angiography, FFR, et cetera? So we have 3 recent trials to actually give us some sort of guidance, and these are a little bit out of order in the temporal way that they were presented. But first was the CVLPRIT trial, and this was a 300-patient randomized trial in which patients with multivessel disease, after successful primary PCI, were randomized to either immediate or delayed PCI of the multiple lesions versus a conservative or watchful waiting strategy. And you can see that overall, complete revascularization had a better outcome, but this was mainly because of less unplanned repeat revascularization, primary endpoint being death, MI, heart failure, or TVR. So there was no significant reduction or death or MI in this trial. Now, the first trial, which got us all excited, was the PRAMI Trial, and this was a trial that was done at 5 centers in the UK, and it took almost 5 years to randomize 465 patients. And with the primary endpoint of death, MI, or refractory angina, immediate, what they called preventive PCI during the index procedure to get complete revascularization was superior. That is, greater freedom from adverse events compared to no preventive PCI. And in this trial, there actually was a reduction in death or myocardial infarction as well as in refractory angina. And then finally, we have the largest of the 3 trials, which was DYNAMI 3 PROMULTI, which was 627 patients, where the patients were randomized to either a delayed complete revascularization versus infarct artery treatment only with conservative care. And this used FFR guidance to decide which lesions should undergo the complete revascularization. And once again, there were better overall outcomes with the complete revascularization, but that was again completely because of less unplanned revascularization with no difference in death or myocardial infarction. So altogether, we've only got a little bit more than 1,000 randomized patients in these 3 studies, and the issue really is that we don't know if complete revascularization in this setting should be done during the same procedure. Should it be done staged and a couple days later or maybe even a couple weeks later, or should it be done for patients who have recurrent symptoms? And is it going to improve prognosis, that is, reduce death or myocardial infarction, or is it only going to reduce unplanned revascularization, in which case you may have to revascularize 100% of patients to prevent 10 unplanned revascularizations, which some people would say is not the best use of our resources. So this is an important issue because multivessel disease is about 40 to 50% of all patients with STEMI. So let's talk about what these issues are. So Dave, let me start with you. You're a very careful reader of evidence-based trials. So how good is the evidence? And you know, it was just a few years ago before we had any of these randomized trials where it was verboten, right, to do complete revascularization during the acute index procedure.
Right. I think I don't think we have the kind of evidence that we really want to guide our practice now. Perhaps the strongest level of evidence of that is the fact that there still is a very large ongoing trial that we're actually the leading U.S. recruiters for, called Complete, which is testing this strategy once again. So there must be equipoise still out there as to whether it's useful. And I think it's because of the reason that you said, which is the benefit seems largely to be avoidance of repeat revascularization, but doing a whole bunch of revascularization so you can avoid some that we classify differently, isn't necessarily the best thing to do. I do think what the data seem to me pretty clearly to show is that it's safe.
Right.
Again, the reason there was the level of, the Class C recommendation for a long time was because it was perceived not to be safe, it was perceived to be harmful. At this point, I think these 1,000 or so patients who've been randomized show pretty convincingly that some form of either immediate or delayed stage revascularization is safe. So I think that can be, I think we can take that issue off the table. But there doesn't seem to be, a clear benefit yet. Although again, there's, there are these hints of signals in there, but I certainly don't feel compelled as a practitioner to treat every one of these patients. And again, I think the best evidence I have of that is the number of patients I put into this complete trial.
So Roxana, you've got a patient who's having a STEMI, a closed LAD. They were asymptomatic before. This is how they presented. And now you do your angiogram, and they've got 50 to 80% lesions also in the right and the circ. So first of all, what are we treating? When we do complete revascularization, are we trying to do complete anatomic revascularization? Are we trying to treat ischemia-producing lesions? Are we trying to prevent vulnerable plaque ruptures in the future? We know patients with ACS have more vulnerable plaques. Are we trying to prevent angina? And because I think we need to understand what we're treating, what the goals are, before we can decide if it should be done at all, let alone in the same procedure versus in a delayed fashion.
I think we're trying to do all those things, right? I mean, the answer is all of the
know.
above.
I don't know.
No, I think it is. I think, with our medical therapies, we certainly are trying our best to, abolish thrombotic events at the risk of bleeding. We know we're going to talk about that soon. But on the revascularization strategy, I think complete revascularization for me is ischemia-producing lesions, functionally ischemia-producing lesions. I think that's what we know is what's best to do for complete revascularization. Certainly, the FAME trials have shown us that, not in the setting of an acute coronary syndrome, and it's a very, very difficult question. So I think what the at least the DAPT investigators did try to do is to, when they were doing complete revascularization, they were guiding it with some form of FFR to guide their therapy at the time of revascularization, which I think is a great step forward. The other investigators for the other trials didn't do that, and frankly, I was confused. I remember asking the PI of the PRAMI study, who are these patients that you were able to do after, who were these? And he couldn't describe them. So I think it's very hard to kind of generalize this to the general
But interestingly,
public.
they had a reduction in death or
In
MI
death and
in
MI.
PRAMI,
So they did
where
a good job
DAPT,
choosing
they had
them.
absolutely no difference
That's
in death or
right.
MI. So maybe those are the wrong lesions, because I always ask people, I've asked Bernard de Bruyne this and Nico Peels, is why does ischemia cause death and MI? Okay, and the answer is it doesn't. It presumably is an indicator for large, bulky, vulnerable plaques. So Freek, what do you think? I mean, what are we trying to treat here? What are the goals? And do we have enough evidence to know when we should treat and what should guide our treatment?
Yeah, the problem I have with the 3 trials is what is control treatment. Of course, opening up the infarct-related artery, no discussion. But then, do you give just medical therapy, or do you do a stress test?
Right.
Or, and if you do a stress test, I think that is a pretty good dynamic test about all the lesions that you have seen.
Yeah.
And I'm not so sure whether they all underwent a proper exercise test before they went home. So that's for me the big question, the comparison. It's not placebo-controlled. It is controlled treatment, which is a very broad gamma.
I think the main goal, I certainly think the concept of PRAMI, when it was articulated, was to ward off these bad thrombotic events. I mean, I think that's the. I mean, why else do
Preventive angioplasty.
Yeah, preventive
Preventive
angioplasty. So
angioplasty.
I mean, the idea is really to try to find the vulnerable plaques
Right.
in some fashion. As you know, we don't have great tests for vulnerable plaques at this point. Even the tests we've done have limited sensitivity and specificity. We have predictors, but we don't have great reliable predictors, I would say, for it. So it's hard to to pick these lesions. But that's the concept. So I think the idea of doing it to prevent angina. I mean, we have it's not that big of a rush. If somebody goes home and then 2 weeks later they have angina, you can bring them back. The problem is if they present, their next presentation is another infarct,
STEMI.
that's a problem. That's
a big
what we
deal.
really worry about.
Because we don't know that any of these patients are having angina. So we don't know if we're treating, even in the FFR positive lesions, are we treating silent ischemia? And, from Courage, I mean, those are the patients that actually worsened quality of life in, the ones that we were treating silent, at least silent coronary artery disease in Courage. So I think what we all agree with is that we all agree conceptually with this idea of complete revascularization. We don't know what we're treating. We don't know how to guide the identification of the appropriate lesions to treat. And we don't have any firm evidence yet that we improve prognosis in terms of reduced death or MI. We have pretty good grounds that we can already prevent unplanned revascularizations, even though these are unblinded trials, but putting that aside. Although, again, we got to treat a lot of people to prevent those unplanned
and the other thing we don't
revascularizations.
know, that I think everybody agrees on in the field is we don't know the right timing to do this either. We have trials which tested, doing all the lesions in one sitting at the same time as their
Versus
primary
both.
PCI, or staging, or mixing it all
why I
together. Again,
think-
most of us, I think, practice, staging them because there doesn't seem to be that immediate
Hopefully
urgency. But we don't know.
complete, which is delayed versus conservative, will give us, at least for that question, more
Complete
useful
isn't going to
information.
show you whether at the time of PCI
Right.
or
No, they're
in
not
the
testing that.
hospitals. They're not testing that.
Actually,
they
they're
really
testing in
are
the hospital.
testing.
Well, in hospital,
They're
it's
testing
delayed.
it in delayed meaning sending the patient exactly. So they're testing.
It's just not acute.
Not
index.
acutely, right, at the time of the procedure.
I mean,
So I
something
think
happened
it's
in complete. I mean, as an investigator, I think that, the protocol got. They didn't modify the protocol, but they actually sent out an alert that said we want you to do the staged PCIs in the hospital. Because I think that, it's a lot of Canadian centers in the study, European centers, and a lot of them were sending them home and bringing them back. I feel like there must have been something happening that made them do that. I mean, again, that was the U.S. practice already, but I think
And
in
then
the rest
that's
of the world
just
it wasn't.
angiographic guided?
It's,
however you want.
I mean, they have 70% or greater lesions in 2.5 millimeter or greater vessels.
Okay.
that's the basic criterion.
Basically.
And
For
how is the control arm in
and the control arm is good medical therapy. There's no requirement for stress
ischemia
tests. There's no,
guiding, no?
no,
No
it's
stress test?
but it's the primary, but it doesn't have repeat revascularization as an endpoint. It's got
Okay, that's
death
good.
or MI
That's
is the
good.
endpoint. So
And they're all getting PCSK9 inhibitors, right?
I don't know about that. I don't know that. That's
All
a
right.
different talk. That's a different talk.
All right, let's go on to the second topic here now, which is DAPT use in patients with acute coronary syndromes. So if we look today at what the guidelines are, from the 2014 ESC-EX guidelines, they recommend 12 months of dual antiplatelet therapy in all patients after acute coronary syndromes, stented or not stented, PCI, not PCI, unless contraindication. And they also say that new DAPT, that is ticagrelor or prasugrel, I'll use the names, are actually preferred, and this is class 1B level of evidence. Now, the 2014 ACC-AHA guidelines are really, I think, irrelevant. Let's go right to what came out in 2016 from a few weeks ago, and that is they basically say there's a mandatory period, and this is primarily after stenting, but in all patients with ACS, there's a mandatory period of at least 1 year of dual antiplatelet therapy, regardless of the underlying therapy. And after that, with a class 2B level of evidence, you can consider longer-term DAPT. It may be reasonable if basically the risks of ongoing thrombosis seem to be greater than the risks of bleeding or other adverse effects. And the question is, of course, how to identify which of those patients in whom the benefits outweigh the risks. So let's look at some of the data. TRITON-TIMI 38 has certainly shown us that within the first year, that more potent dual antiplatelet therapy compared to less potent dual antiplatelet therapy, that is aspirin plus prasugrel compared to aspirin plus clopidogrel, in patients undergoing PCI who presented with acute coronary syndromes, have a reduced rate of death and MI and stroke. Primarily a reduction in myocardial infarction and stent thrombosis. As we all know in this trial, bleeding was increased, major bleeding, life-threatening and fatal bleeding, and there was a neutral effect on overall mortality. Now, the PLATO trial was even more positive. This actually was more the upfront treatment in all comers with acute coronary syndromes, ticagrelor versus clopidogrel, and the curves didn't separate immediately. It took a couple weeks for them to start separating, and that's perhaps because everybody got treated right from the beginning and even before going to the cath lab, and then they gradually diverged over time, and 1 year later there was about a 15% reduction, again in cardiovascular death, MI, or stroke. But in this trial, there actually was a reduction in CV death as well as MI, in addition to all-cause mortality, in addition to stent thrombosis. And that's because all bleeding was not overall increased. It was very similar, and there was no increase in life-threatening or fatal bleeding. Now, non-CABG TIMI major bleeding was increased with ticagrelor compared to clopidogrel, but there was a neutral or even slightly less CABG-related bleeding, presumably because of the shorter half-life of ticagrelor, which facilitated surgery in the patients that need it. Nonetheless, this was a very positive trial with reduced all-cause mortality in 18,500 randomized patients. But again, this goes to the first year, showing that more potent dual antiplatelet therapy in PCI patients with either drug or in medically treated patients with ticagrelor improves prognosis. Now, the question then is what to do after 1 year, and in whom might this be beneficial? And here we've got data from the DAPT trial. These were patients who received drug-eluting stents, and this is the data looking at patients who presented with a myocardial infarction. About 3,500 patients, or 31% of the entire population, presented with either STEMI or non-STEMI. And if you look at 12 months versus 30 months of dual antiplatelet therapy with either clopidogrel or prasugrel on top of aspirin compared to placebo, you could see that in this additional period, there was a fairly marked reduction in stent thrombosis. There was a reduction in major adverse cardiac or cerebrovascular events. This was offset by more than a doubling of gusto severe or moderate bleeding, and at least mortality was neutral. Unlike patients without myocardial infarction, where mortality was quite increased with prolonged DAPT. So I think this is really an important rationale for a Class 2B indication, suggesting, yes, you can further reduce ischemic events, and this held for everolimus-eluting stents as well, although the absolute differences were not as powerful as with non-everolimus-eluting stents, although there is a price to pay, and that is more than a doubling of bleeding. Now, we also saw in the PEGASUS trial a large 21,000 patient trial of patients who 1 to 3 years earlier had had a myocardial infarction and now had, in addition to that, also had additional high-risk features. And these patients were randomized to continue aspirin alone or aspirin plus ticagrelor with 2 different doses, either 60 milligrams twice a day or 90 milligrams twice a day. And over a follow-up of about 3-year period, there was a significant reduction in the primary endpoint of CV death, MI, or stroke, but about a 1.2% absolute reduction over 3 years, so about 0.4% reduction over 3 years. And all 3 components of the primary endpoint were equally reduced. What we did see in this trial, though, is that there was a marked price to pay for increased bleeding. Remember, now you're looking at a placebo instead of another agent. So it's aspirin alone or aspirin plus ticagrelor. And you can see that overall, TIMI major bleed was doubled, TIMI minor bleed was tripled. Fortunately, there was no difference in fatal bleeding or intracranial hemorrhage. Overall, ticagrelor 60 milligrams BID came out slightly, it looked like had a slightly better benefit-risk profile for use in this application. Overall mortality was once again neutral, presumably because of somewhat of an offsetting of the risks and benefits of bleeding versus ischemia reduction. And then finally, there have been meta-analyses. There always are, and there are in this field as well. This is looking for 12-month DAPT alone versus more than 12 months, looking at a variety, a mixture of different clinical scenarios, patients who had received drug-eluting stents, PEGASUS, which I just described, Arctic interruption, Prodigy, Charisma. This is primary and secondary prevention with coronary artery disease, so a real hodgepodge, and overall showing something very similar to what we just saw with PEGASUS. That is neutral mortality, increased bleeding, but reduction in ischemic events. So there's clearly no free lunch with dual antiplatelet therapy, both either early or late, arguably perhaps with ticagrelor in the first year. We can talk about that. but there's a trade-off of bleeding versus ischemia, and then the question is how to identify the right patients who beyond 1 year should be treated with additional dual antiplatelet therapy, and then which agent. So let's start with this. So Freek, let's go the other way now. So what are your interpretations? I'd be interested in what you think of the new guidelines that just came out a few weeks ago from the U.S. And how do you identify which patients should be on more than 1 year of dual antiplatelet therapy with acute coronary syndrome?
I think age is the most important factor. The older the patient get, the more the risk of bleeding. So I would say patients over the age of 75 should not be on dual antiplatelet therapy in general. Of course, patients who had the bleeding before should not be in. You should realize that both trials included patients who had a course in the first year without any problems.
Right.
No stent thrombosis, no bleeding. So this is a selected group. But in general, I would be very reluctant to give it to the elderly.
Regardless of other risk factors? If they got
maybe
6
gender.
stents, if they have diffuse
gender
coronary
maybe also an
disease.
issue. Gender maybe the female patients tend to bleed more often, and that would, I think, for me, the most important risk factor, the age. And other risk factors like previous bleeding, usually they are not in these trials, and therefore I have to be a little bit cautious. So that is my opinion about the two trials, but both show at least a benefit without any discussion. That they don't reduce mortality, that is a very interesting issue.
Yeah.
If you reduce stent thrombosis and MI to very unpleasant complications, you would see a mortality benefit, and you don't. So probably
and not
the
even
bleeding.
a signal towards a reduction in cardiac mortality. I guess in PEGASUS there was.
but
that is such a difficult.
yeah.
That's such a difficult split up. Cardiovascular mortality on non-cardiovascular mortality. That's cancer
It's
mortality.
difficult. So look at all-cause mortality. I agree.
But,
So Roxana, let me. The DAPT investigators, I think, have come up with a potentially important score to try to figure out how to individualize risk. This was published recently in JAMA, and the score has 9 different clinical and angiographic factors. And by their suggestion, they looked at unique factors for ischemia or bleeding, but not both. And they suggest that about half the patients would benefit from prolonged DAPT. From that analysis, where half could potentially even be harmed. What's your opinion of?
I thought that the DAPT score was a great step forward in trying to actually understand the DAPT study, which I think it did show that half of the patients, and it was really split halfway down the middle if you actually look at it. Half of the patients benefited tremendously without bleeding issues, and the DAPT score could help you figure that out and who those people are. And I think I think it's a tremendous step forward. And however, having said that, I think it's important that people understand that the DAPT score is not, as Freek just described, is not at the time of PCI, but after a patient has gone through a whole year of
event-free patients
event-free patient at 1 year, then you're evaluating them and looking at that. And I think that was, and one of the other things the issues that I had with the DAPT score was the fact that on the bleeding side, they were somewhat anemic, no pun intended. They didn't have anemia, prior bleeding, the kinds of things that, because it wasn't collected. And I wish that they had those, because I think you could be a better. And the other one, and I know that Dave was involved with both the PAIR score and the DAPT score. The C statistic is 0.6. And I know I don't put too much. It's a little bit better than a flip of a coin, but I don't know. I don't want to put too much weight on the C statistic in the DAPT in a score. And its validation was in a trial that is sort of very, with cipher stents, and I think it's a difficult application.
It really hasn't been validated.
Right.
I
So I think
you could
those are
make
the
that
issues.
strong
the
argument.
CHAT score for AFib has almost the same C statistics, and we use it day and night.
I think the C statistic is a very misleading
It's a
thing when you're
misleading.
especially when you're applying it into these sort of populations. We've been struggling with it in other applications. So I think that's one thing we should, probably.
Just not talk-
we
talk
should
about
make
it.
sure
Look
it's
at
bigger
the
than
NRI
0.5.
and the IDI.
Yeah,
the net reclassification index and the interval
and ideally
discrimination index.
and ideally the calibration. You want it,
Yeah, sure.
you want it to faithfully if it says the person is going to have a 4% chance of having an event, you want it to have them to have a 4% chance
Right.
of having an event. The problem with using a statistic to evaluate something like the DAPT score is there aren't any patients who have a 95%
Right.
chance of bleeding,
Right.
And there aren't any patients who have a 0% chance of of bleeding. There's
Exactly.
the ends are not anchored enough, and so that's what So we're looking for discrimination like PCI mortality models where you have C statistics of 0.9.
Right.
You
not
might
gonna
you might as well
happen.
get in a different field
Yeah,
because
sure.
you're not going to find
Yeah.
them in the DAPT score or anything like it.
The biggest thing to me is that, Roxana made two important points, that several important bleeding risks, okay, especially prior bleeding and anemia, unfortunately they don't have it in the database. Chronic oral anticoagulant use is the other one, but that's kind of a very special population.
That was excluded from the trial.
No one's thinking
It was-
of
it was-
lifelong triple therapy
Yeah,
in
nobody's
those
doing
patients,
that,
right? The validation is, though, a very important issue, and it actually took me a long time to realize this. Of course, the data is going to look good when you look at the best data created from a multivariable model within the trial and then apply it to the trial data. What you've got to do is look at external, another randomized trial or real world data or something to then see if it behaves as well.
Yeah, I mean that would be the ideal. I
Right.
mean, the closest thing they probably have to doing that is right up the street is to use the PEGASUS data.
Yeah.
Actually, which is
Exactly.
at least has some
Seems like
rough
that needs to
similarities,
happen, right?
to do it. And they're just
Yeah.
Bobby's just across the street from where Mark Sabatine works, so they ought to be
Right.
able to get
Hopefully-
together.
hopefully
Right.
they'll
To,
do it.
Right.
Yeah, that's how
to do that at this.
Yeah, and I'm sure we've got databases and other people do too that I think are
But really,
going to try
to really look at it, you want
Right.
another
You'd
randomized
like a
trial,
randomized
of
trial.
long versus short
Right,
DAPT,
right.
which is there aren't that many of them.
Right,
Right.
exactly.
And the score is also a little bit impractical. It has plus and minus, where for instance,
Yeah.
CHOP score is just adding, and this is something.
Oh, yeah, I guess interventional cardiologists, we probably shouldn't be too
can't-
proud
we
about that, but
can't have too much
Well,
math.
there-
it's
there's-
really pretty simple. I mean, because it's
Yeah.
I
It
mean,
is
basically, if you're over 75, you have to have about 3 or 4 factors in order to get
Right.
over
Yeah, but it's
2.
not the
And if you're under
interventionalist.
65, just ACS and one thing.
Yeah.
It is not the interventionalist who decides; it's a doctor who sees the patients
well,
a
no.
year after the intervention.
Well, I've been arguing. I'm still working on it in our own group. What I've, my full intent is to get us to put until somebody publishes something better, is to put the DAPT score into every single cath report. Just put it there, make it the last line in the cath report to get this patient's DAPT score in a year is going to be, because you can calculate it. I mean, it's meant to be applied a year later, but you can calculate it at the time it's done.
But things
Put it
might
in there.
change, and
Things
it's got to be
change.
event-free.
What's going to change?
I mean,
Diabetes.
diabetes,
Yeah.
patients will be a year older. I guess you could.
No, but the year of the age is
Yeah,
the age
you
you
know.
can calculate. I know,
Yeah,
I know
yeah.
exactly how much older they'll
Yeah,
be in a
yeah,
year.
So, one of the important issues, though, is, and I can't remember the last important issue.
Well, I mean, there's a lot of
Uh,
important
I
issues.
think
well, there's a
that
lot of important issues, but-
I think one of the things we should talk
Yeah.
about is do the ACS patients deserve special attention to be given prolonged
Oh, I
DAPT?
know what I was going to talk about. Well, the answer is yes, they should, because they've
course.
got a much higher event rate. They've got
Absolutely.
more vulnerable plaques. They're more likely, half this
Regardless
reduction
of their
in-
bleeding
in
risk,
myoc-
Gregg?
Regardless of the bleeding risk, they have a higher ischemia risk.
No, I know, but
Yeah.
would you?
Let
would
me bring up this point. What was fascinating here, and this is interesting, what was fascinating was that even in the top 2 DAPT scores, okay, the 50% that
Oh, right,
really,
right.
2 and above, that really did benefit, mortality was
Mortality
neutral.
was neutral.
There was a marked reduction in MI and stent thrombosis, not much increase in bleeding, but even within that data set, mortality was neutral. And is it possible that MI and stent thrombosis is not what it used to be? Much of these MIs are little tiny MIs. They're unstable angina. And we've gotten very good at rushing them to the lab and stopping any badness from happening. And stent thrombosis, there's differential impact of stent thrombosis, with early stent thrombosis apparently being worse than late stent thrombosis. So are we able to, it sounds awful, stent thrombosis MIs, but it seems like we're able to interfere with the natural history of a lot of these events.
Well, I think it's a fair point that the MIs are not what they used to be.
Yeah.
That again, a lot of them are based on troponin or high sensitivity. I mean, again, we have very sensitive tests that allow us to pick up MIs in a lot of patients, and they're probably less prognostically important than if you did the same study 10 years ago and found the same sort of thing. Again, as somebody who was involved in the study, I have to again, make that disclaimer. I think you should not be overly distracted by the fact that there's no mortality difference in a study that by the time you slice it into that, is way underpowered for mortality. You know that. And you're talking about half the study now.
Yeah, but not even a signal. And
Well,
even in the
but
meta-analysis.
what does not even a signal mean when you're underpowered to find it?
Well, it's, when you've got power, you've got a confidence interval around it. So you do have some
Well,
power,
if it goes
right,
in
in
the
every
wrong
study.
direction, that's when you start to
Yeah,
really
I mean,
scratch your
it
head.
goes strongly in the
And
wrong
that's-
direction in the two lowest DAP score groups. I mean, that's for
Yeah.
sure. I mean, it's a.
Well, there
you know,
it's-
I mean, I think so. I mean, I think I mean, I can certainly at least agree that I can use the DAP score to figure out who not to do it in. I mean, we might disagree about whether if your DAP score is 2 and above, you ought to
Right.
prolong it. But I
It's
think
ve-
if it's
I
less than
agree.
2, we should.
That's
not.
that's very clear, and that's why I think it's a 2B. It could be a 3 for certain types of patients, and then a 2B for the others. All right, so let me ask this last question, Freek. I'll start with you. You've decided you got a patient who you want to have prolonged DAP now.
Yes.
Okay, which drug?
Yeah, that's a
that
very
was
good
coming.
point. That depends again on which drug was the patient on in the first year. If the
Okay.
patient was on ticagrelor, I would continue this, because if you look in PEGASUS, the patients who had a very short interval between stopping
Right,
DAPT
they
and getting
overall
randomized
did
into the
the
trial,
best.
the benefit was there. If you start late, forget
Right.
it. That supports the idea of long-term
Continue
DAPT, right?
therapy.
So I think ticagrelor has very good papers, and for the prasugrel there is good papers in the DAPT trial, right?
Yeah.
So I think it doesn't make a lot of difference what kind of drug you will take for long-term DAPT. Long-term
There's a cost difference. It's a
clopidogrel.
substantial cost difference.
Yeah, it's a cost
In the
difference,
States,
okay,
for
but
sure,
that's only a
Yeah.
temporary thing.
Yeah.
But if you are afraid of bleeding, maybe you can go back to good old clopidogrel. It has less bleeding, at least. So that's also, you can make a case for clopidogrel, especially when a patient has been on clopidogrel without any problems in the first year.
Roxana, what do you think?
Well, I agree to a lot of degrees with you, but I think if I am going to prolong if a patient is on ticagrelor beyond a year, I'd probably put him on the 60 milligram dose for
Oh,
sure.
yeah, you see, yeah.
I think, because the data was so strong and the benefit was still there and the bleeding was that much less. And so I certainly would go in that direction. I'm hoping we can prolong patients give patients and put them on monotherapy and try to take away aspirin, but that has to be proven. I think, we're going to look at global leaders, but in a double-blind, placebo-controlled way. Hopefully, the Twilight study will help us understand that. If there is going to be prolonged, instead of putting them on clopidogrel, I'd rather withdraw aspirin if I can and reduce the bleeding complication and give the patient the ischemia benefit, if we could. But obviously, we need to really, really examine that. So I think those are the,
All right, Dave, let me give you the last word. Regardless of what prolonged DAPT you use, how long? Okay, another 1 year, 18 months, lifelong?
Until they have a problem. I mean,
Yeah.
I think the data on that actually are pretty clear, from the DAPT trial especially, which looked at what happened when you stopped. And when you stopped, bad things happened. And so, the curves, both PEGASUS, the curves are diverging at the end of the study. DAPT, the curves are diverging at the end of the study, and then come back together during the 3 months when you stop it. So I think the answer is, in for a penny, in for a pound, or something, whatever that saying is. You should keep it going until either until they make it to 75. When they're at 75, I think they've
maybe
crossed
then,
some magic barrier and they probably have
Yeah.
to stop.
And then they
Maybe.
get a fib.
Yeah, exactly. But I think so,
Yeah.
I think very long term is the answer.
I think that first bleeding event, though,
Well,
could
no,
be
that's-
the really bad
See,
event.
well, see,
So
that's
I
what's
get nervous
interesting
about
because
that.
nothing bad happens until it happens.
Well-
It can be bleeding or ischemia. And in fact, from the PEGASUS data, that data on the fact that starting it a couple years after the MI didn't make much of a difference suggests that there is a period after which probably a lot of the plaques are passivated and the event rates stay high early and then they probably start to plateau out. We saw that in
That's a
Prospect.
biomarker, though. having a
No, we saw it in Prospect.
No, but being okay for like 2 years without taking stuff means you're a certain kind of patient.
Yeah,
I mean, I think
selection
that's.
of
I
No,
think
no, no, but I'm just talking about, for example, in Prospect, a pure natural history study when we looked at non-culprit lesion-related events, 2 years, pretty linear, and then from 2 to 3 years, it started to flatten out. So I think there is a time period where plaques do stabilize. Systemic inflammation is probably not as high as it used to be.
No, I mean, I think, definitely, so far, I will say the data say we haven't gotten to that point yet. It isn't 33 months.
Yeah.
It's not 30 months. It's something beyond that. And so I don't know where to stop.
So I'm
shy of
thinking
that.
before we exsanguinate all of our patients,
Yeah.
We gotta do
that
more
we've got
studies?
to, no, I think we've got to go after another mechanism to passivate these plaques, Greg. And I
Not
think,
anticoagulants.
and I think we are
antiplatelets.
really reaching, either we start withdrawing some of this, some of these stacking therapies, as you call them, and
Yeah.
I've seen your lecture
Well-
on it, or we move to a different mechanism. What do you think?
No, I do agree. I think a lot of that mechanism is obviously LDL hypothesis, but that's getting at it from a different point of view.
very different.
I mean, I must say, from PEGASUS, as impressed as I was with PLATO, okay, and the major benefits of ticagrelor compared to clopidogrel within that first year, I was really underwhelmed with PEGASUS. 0.4% difference per year with 4 to 5-fold bleeding, marked increases in dyspnea, increased gout, I mean, and $4,000 to $5,000 a year, I mean, in cost.
Yeah.
So I was very underwhelmed with the PEGASUS
And in a
results.
selected population, for instance, prior stroke was excluded in,
Right.
and prior stroke is.
Well, I think you have to be
Well,
careful.
now,
You have
to be
but
very
we're,
careful with the prior
but we're going to have
stroke patients.
Socrates coming out. Well, in PLATO, it looked okay. The prior stroke
Yeah.
patients did fine in the first year. Long term is different, and we've already heard that Socrates is a negative trial.
And I do
So-
want to, I just wanted to, put in at least one plug for ticagrelor, and I'm not, in that if you're looking for a hint of a mortality signal, I mean, the all-cause mortality at least
Yeah.
went in the right direction with the 60 milligram dose
No
in
question.
PLATO. I mean, it was not, it was,
Okay.
In
it-
Pegasus.
I mean,
In-
it's
in
Pegasus, I'm
Pegasus,
sorry,
yeah.
Pegasus. It was,
Even
you know,
stroke was in
yeah.
the right
Yeah,
direction.
so I
Yeah.
think it's, I mean, again, I don't think it's completely closed, but I think, I think we're definitely getting near the,
Right.
near the flat of the curve.
And what we still don't know from Pegasus yet is how many of those patients were stented for their MI, so were DAPT-like patients versus
80%.
But
About
when were they
80%
stented?
got an intervention for the index MI.
80% had
Yeah.
prior stenting.
Yeah, no, we don't.
They've
we don't-
not yet reported that to my
No, no,
knowledge.
no, but that's
because I've asked them
that-
4
that's what
times,
we,
and I'm trying to get that information.
Apparently that's
Yeah,
in-
yeah, that's
80% had prior stents,
Yeah.
but I don't know if they were stented for the index MI or not.
Most got intervened for the index MI. Yeah. That-
Sure,
that-
most
Well,
of
we
them,
have
but
to-
we haven't seen it. We haven't seen
We
it.
just have
No,
not
we
seen
haven't
it.
seen that data.
And we
I
haven't
just
seen the
don't-
subgroup broken
No.
down
Yeah.
by those patients
No,
versus.
that's,
Yeah.
that's true.
But
yeah.
it's-
Anyway, so I think we all agree that 1 year of dual antiplatelet therapy for ACS. I think we're all fairly impressed that ticagrelor, the data was very strong from the PLATO trial. After 1 year, I think we pretty much all agree also with the 2B recommendation. Some of us may say 2A, 2B,
Yeah.
but it's finding the right patients who are going to have a greater ischemic benefit compared to bleeding risk from long-term dual antiplatelet therapy. So that ends it for this interview wrap-up period. I want to thank Freek, Roxana, and David. This was a fantastic discussion, and let's enjoy the rest of our time in
you.
Seoul.
Thank
you.
you.
Greg.
Thanks,
It
everyone.
was a pleasure.